you have to get HR on board. You have to have a good salary structure for these people so you can retain them. They become invested. You'll end up getting people who are motivated by this and will stay. And then I think you have to ensure that you have good leadership within SPD. I don't think the surgeons are going to be the ones that are punitive. I think, the problems we've seen are that you have leaders who are insecure and want to have complete control and watch everybody like a hawk rather than trying to figure out how do we improve the system. If I can reduce the stress on these people, they'll perform better. So I think there's multiple levels you have to approach this. There's not just one sort of silver bullet that fixes all of it.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Peter Nichol, Chief Medical Officer at Beyond Clean and minimally invasive pediatric surgeon, healthcare leader, innovator, and entrepreneur. As Surgical Director of OR Services at University of Wisconsin Health, Peter has overseen the rebuilding of sterile processing, optimization of operating room efficiencies, and change management of OR culture and environment at the American Family Children's Hospital in Madison, Wisconsin. Peter is also the founder of Cars Curing Kids Foundation and co-founder of Kids Health Vista, not-for-profit 501c3s dedicated to funding initiatives that will improve the health of kids in the state of Wisconsin within 1 to 3 years. And Paul, I believe that very early on in the developing or emerging Beyond Clean as a podcast, you worked with co-host of Beyond Clean, Hank Balch. And I remember he was at Peter's hospital and they had a chance to meet. And at the very same time, Peter began to do some extensive work, which he's going to talk to us about today in the field of sterile processing. And you've done a lot of work in this regard as well. I'm really excited for this one.
I am so looking forward to talking to Peter and finding out more information about this research that he's doing. Having been in the OR for 40 years, I've always been curious as to what we can do to improve the relationship between the OR and sterile processing, and the fact that sterile processing can impact the OR in so many different ways. I know he's got some insight. He's really the first surgeon I've ever met that has spent any time down in a sterile processing department to really see what's going on. And I think it's really opened his eyes, and hopefully he'll be able to open up other physicians' eyes to this whole issue and really become a champion for the sterile processing area and how it impacts the OR.
Yeah, I'm looking forward to this one. We're going to be right back with Peter Nichol after a short break.
You're listening to the First Case podcast.
Joining us now is Dr. Peter Nichol, Chief Medical Officer at Beyond Clean, our sister podcast. And I'm now going to refer to you for the rest of this interview as Peter. You and I know each other quite well, have been working together for about 3 years, Peter. And I'm really excited to talk to our audience today about not only some of the great research, but I think everybody needs to hear your story. And that story revolves around sterile processing. So welcome to the show.
Thank you, Justin. It's a pleasure to be here with you again.
Yet again. And
yet again.
Peter, can you tell the story for everybody about how you got involved in sterile processing, why you took such a great deal of interest and ultimately led you to write several articles and begin research?
Yeah, so it was back in 2017, and I was on vacation with my family in Santa Monica. and I received an email from one of my pediatric orthopedic surgeons that for the third time in 2 weeks they had found debris on freshly sterilized instruments for one of his spine cases. And the hand waving that went on in the subsequent emails from the various leaders within the hospital completely set me off. And I sent back a pretty terse email saying, look, if we were manufacturing airplanes and we had this kind of quality problem, we would shut down the manufacturing line until we figured out the problem because lives are at stake. And there's more hand waving because of that. And after that, I was on a mission and I was not to be deterred. So I spent time going through sterile processing. And Justin, as you know, the thing that struck me was the complete lack of organization, what is a very high-tech, high-stress space, which really should be structured like high-end manufacturing. And the immediate thing that became evident was we need to start reducing the number of instruments and pans because we're processing stuff that we never use. And that's going to contribute to a higher error rate. So that's how I kind of got launched. That's where we started. And that led to my first article, which is how I came into your orbit.
Yeah, that's fantastic. You mentioned when we were talking earlier about staffing in the sterile processing department. And I'm interested, since you are a surgeon yourself, and you know that so many of the metrics that administration and organizations place on key aspects of the OR, such as turnover, on-time first case starts, how does the impact of low staffing in sterile processing impact some of those key indicators?
Well, so I think it's a combination of low staffing and probably not optimal staffing, not having enough people at the critical times throughout the day when you're getting piled on with pans. But you end up with delays, and you end up with delays because stuff is being processed and is not available, and you're stacking cases because you don't have good OR smoothing, in spite of them paying attention to all these metrics. I think, moreover, the bigger issue is that by our estimations, and we're starting to look into this now research-wise, probably 1 in 3 cases has some significant problem or delay because the instrument's not available, or it's not in the right condition, or less likely there's bioburden. But there's stuff that's missing all the time. And because there's a high rate of turnover in sterile processing, and because there's a lot of specific service line knowledge that cannot be preserved when you have high rates of turnover. So you have individuals who know stuff about certain service lines, and then they leave or they get reallocated because you're continually struggling because you don't have enough FTEs to do the work. Things get lost, they get misplaced, and it has a huge impact on capacities. I would estimate in our children's hospital and our adult hospital, which are next to each other, this is costing us probably close to $12 or $13 million a year, just in lost capacities.
Wow.
Yeah, that's pretty incredible. Peter, you were saying that, there's these shortages. So it sounds like there's a supply and demand issue within the industry for sterile processing employees. And if we're talking about $13-14 million a year within your organization, what are they doing to try and increase the supply?
So supply is part of it. Part of it is that there's really not great training. There's some certifications online. There's only a couple of technical colleges I know that have a curriculum where they train people to do this, and they don't do it in a really comprehensive fashion. So we're not doing enough in terms of making it into an attractive working environment where people want to go and stay. The thing that struck me about the people that work there that stay, they're very, very mission driven. They're very purpose driven. They understand that what they're doing is very, very important in terms of the delivery of healthcare. But the hospital does not understand that and does not reward that. And I think Justin knows this. Hank and I have been fighting a battle with my medical system to raise the salaries. And our argument is if you just simply raise the salaries to stabilize the work environment, you'll have less turnover and we'll get deeper institutional knowledge about what's going on, and things just by doing that will get better. So in order to improve it, you need to make it a more attractive environment to work in, meaning you have to pay people more. You also have to give them an opportunity to engage with the other people involved in all this, which is the surgeons and surgical teams, in a meaningful way so they have input. People want that. You have to exploit their desire to be purposeful and mission-driven in a good way so that that can be leveraged for the betterment of the system. And then I think in the long term, you've got to start coming up with curriculums at technical colleges that will provide the kind of education that people can come into this and really hit the ground running and grow within those environments professionally.
Yeah, I think you hit on a really good point there about that relationship between the OR and sterile processing. You know, oftentimes we operate in silos in these two departments that are really interdependent upon one another. And there's a level of trust that has to exist between those two departments. And can you talk a little bit about how staffing and leadership can impact that trust and the impact that has ultimately on patient care?
Yeah, well, I think this is where I've seen it work well. You have people who are in leadership positions, not necessarily administrative, but they're leaders within the OR, and they are interfacing with leadership and SPD and continually looking at opportunities for improvements and giving and receiving feedback. And so, you know, you could talk about the technologies that need to be implemented here, but you also can't replace the human beings. And you have to create a culture where there is interaction. Currently, like we said earlier, these are siloed spaces, and yet they are so tightly integrated in terms of the delivery of patient care that it really, if you step back from all this, it boggles the mind why it has evolved to be like this. Why is it in the basement of every single hospital? And why is it that, you know, when things don't go well, mostly what happens is people get mad and start yelling at the people in sterile processing. That has to change. And so there are places where I think it works well, but most places it's highly dysfunctional and siloed and segregated. And when you don't have that, then you cannot identify your opportunities for improvement and create sustained change.
You know, Peter, in my consulting role, frequently when I'm at hospitals, I encourage them to have joint staff meetings between the OR and sterile processing so that you can get that kind of conversation going between the departments. Has there been any effort within your organization perhaps to try and make that happen? Is there any dialogue going on at a staff level? There's
not structured dialogue, what you're talking about. There is sort of ad hoc, let's call this person, stuff that goes on, but there's nothing formalized or structured. No, unfortunately.
Yeah, and I think that's really an important piece and something that I also stress to organizations is that everybody has to have a seat at the table in order to make this a successful program, both from the OR's perspective as well as sterile processing's perspective. And, you know, if sterile processing doesn't have a seat at the table, then that's going to always be a challenge.
Absolutely. Absolutely. You have to see this as an integrated effort. And I always preach this, Justin knows this. You need a flat hierarchy. You have dialogue that's bidirectional. Healthcare is not set up like that, unfortunately. It's very hierarchical. And sometimes the people at the top really have no clue what's going on at all. And I'm talking about the surgeons. Until something goes really, really wrong, they don't pay any attention to this stuff. And it's not just the sterile processing. I mean, there's a lot of things that have to happen by a lot of people other than the surgeon for an operation to go well. And I think there's generally a real lack of awareness about this at the highest levels from, I guess, what you call the consumers of the product, which is not so much the patient, but the actual surgeon. The person who's in a position to do something about this.
So let's talk about leading by example then, Peter, because I know you just described the scenario of not having an awareness. How did you yourself get a much greater sense of awareness of what this job is really like?
Yeah, so you just go down to sterile processing and spend some time down there and do some of the tasks, and you realize this is hard work. This requires a lot of concentration. It's a noisy environment. Things like inspection, which there's at least 4 or 5 points of inspection for instruments in a single sterile processing cycle. they don't have good lighting, they don't have good ergonomics, they don't have good magnification. All those things that could be improved, they don't get addressed. So I went down and I saw all this stuff and I was kind of horrified. And then I took the dean of the local technical school down there and she said, this is a total mess. This should be really set up like high-end manufacturing, and it's not. Like, this is pre-Henry Ford manufacturing. This is really just not well organized, not well structured. And that was really an eye-opening experience for me. And then I spent a lot of time talking to people and interviewing people. And, Justin, we talked about this in my first podcast with Beyond Clean, I was struck by how mission-driven they all were. In spite of the circumstances under which they're working with a lack of support, the thing that kept them going is they felt that what they were doing is very important for the delivery of patient care. And if you recall from that podcast, I said they really need to be considered as healthcare workers. They really do. And they should be paid like they're healthcare workers.
No doubt about that. You mentioned earlier about there being, or some of the new research you're doing, and one of those things that you're looking at is error rates and the cost of those error rates. Can you give us a little insight into what you're finding in that area?
So the first thing we did was we asked everybody to give an assessment of how frequently we're having, by a series of interviews. How frequently are you experiencing this would be like the nurses, the team leaders, not the surgeons, but the people that are actually dealing with this stuff and having to make the corrections mid-course in the OR. How often do you experience some sort of disruption in your OR flow because an instrument's broken or missing or there's bioburden? And, the number they came up with was pretty startling. It was at least one event per OR per day. So the 38 ORs in the two hospitals, and I'm not counting the hybrid ORs. But when we marched that out and I asked them estimates, what was the average length of time you think of the delay? It's about 8 to 10 minutes, $153 a minute. This isn't capturing the ones that are occurring before the case starts or when something goes missing at the end of the case when you're doing all your counts to put everything back in the pans. The next thing we moved to was doing PSNs, which are patient safety notices. And this is, of course, plagued by a lot of underreporting because somebody has to actually fill out what happened in the midst of an OR day when they're trying to turn over an OR or they're trying to, staff a case. And we also had, so we looked into that and looked at not surprisingly, the service lines that had the highest rated PSNs were cardiac surgery and orthopedics and neurospine, where you have these big pans and lots of instruments. But the students who were working on this said to me, look, by our estimation, what they're reporting is maybe 1/20th of what's really happening. Like there were days where I'd have an observer in the OR and for another reason, and they'd have to break down all the pans for some reason, like bioburden contamination on the back table, and no PSN would get filed. And this would take an hour, of time, OR time, because then they got to get stuff out from sterile processing. It's not ready, all this other stuff. So we now are assembling a team for after the first year to start looking at this and just spend, about a month just observing, sampling the ORs to see how frequently we have disruptions in instrumentation that result in delays and measuring the delays and figure out what service lines. So we're going to do that at the Children's Hospital. So I've got an army of undergraduates who are going to help me with that. The person who did the PSN study is going to help lead that team. So that's where that research is going. We can then take those delays, and we know what the cost in OR minute is. It's $153 an hour, and we can make a very strong economic argument around capacities. And we can also look at, if you have a series of delays, does this push the OR past 5 o'clock? And if you're running past 5 o'clock, then it's twice the cost of running during regular hours. And it also doesn't count in your metrics in terms of utilization. So if you had been able to smooth that out, you might have better utilization and be spending less money. So that's where that research is heading right now.
Wow, that's so needed.
Your research really is focused around the operational loss. There's also, I'm sure, a significant cost that we can't always capture, and that's surgical site infections.
Right. So the problem with tracking those is you really need to be able to track the instruments individually, and we're not there yet. I mean, really to get granular on this, like we can track, there's technology out there that can track pants, but what was it that touched that patient? What got used, right? And the other part that's missing is we don't have a visual proxy for bioburden, and it's too time consuming and too expensive to try and culture every single instrument or swab every instrument before it goes into surgery. You can make an estimation of what a risky bioburden would be visually with high-end visualization technologies. That would make that much easier. But there absolutely is a risk associated with surgical site infections around this stuff. No question about it. There's some other interesting things we found too. So, we're trying to figure out what the impact is of the turnover times having these big pans. So, we've done some early studies around this, and we're finding that the instruments, the percent that gets utilized in the pan is about 20%, right? So 80% of stuff is not getting used. And so we're very interested in if you could reduce these pans and at the end of the case, you have fewer instruments to put away, what is that doing for your turnover times? So we're looking at that as well. All this stuff is very fascinating, but it's in its nascency.
One of the things that I noticed the most as I worked in orthopedics primarily during my circulating and scrub roles was when you're looking at trials for total knees, you have sometimes 15 to 20 trials when, the patient, there's no way that they're going to use the trials on the far spectrums of those. So why are we processing those every time?
Oh, absolutely. Yeah, no, I know. We start looking at implants, number of implants they open for these cases that they don't use. And when Justin and I've talked about this before, then there's all these things that new gadgets get sent in and the IFUs, nobody's ever seen this stuff before. The strain on the system and the stresses it puts into it, they're very, they have a very negative impact on the delivery of surgical care. There's no question about it. And they have a huge impact on efficiencies. And it blows my mind that we can have, just-in-time delivery of stuff manufacturing for Walmart. And that industry knows how to do this stuff, and hospitals simply have not caught up even with the late 20th century with regards to this kind of stuff, much less the 21st century.
Peter, you were talking about how you were tracking all these errors and my question would be is, as you're doing this, is this being focused on SPD? Is it creating some punitive environment for SPD as you're doing this? Or how are you approaching this to make sure that it's done from a more neutral standpoint, as a help for these people versus a hindrance?
So first of all, you don't implement these changes as a leader without being the guardian for those people, right? So I've been advocating and fighting with HR for salaries, and you have to put your mission first. Your mission is the best patient care possible, right? That's what you have to do. So you're going to have the person who's in there that just doesn't have the wherewithal to be working in this high-stress environment and makes mistakes all the time. And they really shouldn't be in that environment then. And it's no different than having, a nurse that keeps dropping balls in clinic and becomes a patient safety issue. But I think you have to get HR on board. You have to have a good salary structure for these people so you can retain them. They become invested. There'll be a selection process, a national selection process that you'll end up getting people who are motivated by this and will stay. And then I think you have to ensure that you have good leadership within SPD. I don't think the surgeons are going to be the ones that are punitive. I think, the problems we've seen are that you have leaders who are insecure and want to have complete control and watch everybody like a hawk rather than trying to figure out how do we improve the system. If I can reduce the stress on these people, they'll perform better. So I think there's multiple levels you have to approach this. There's not just one sort of silver bullet that fixes all of it. But I hear where you're coming from, and I understand there are those concerns. Right now, those people are being abused as it is.
Right.
Right?
Mm-hmm.
You talk to like Lisa Wakeman, and they pay people $13 an hour to do the stuff down in Indiana in these horrible environments with a lot of noise, a lot of heat. I have a friend who does high-end sterile manufacturing in the biotech world. And when she got a tour, she's like, none of these people are wearing face shields. None of them are wearing masks. All this stuff's getting sprayed down with hot water and aerosolizing. I dread to think what they're breathing in. She was horrified. That's the environment we're in now. It's not a safe environment. So they're already being abused.
Absolutely.
And it's already, I don't want to say punitive, but it's a dangerous environment. So we need to make it a better environment.
So, Peter, what I'm hearing is not only do you say environment, but I'm thinking equipment and supplies that bring the department up to date.
Yep.
The other one is to right size the pay scale and give them a career ladder.
Absolutely.
And let them grow within the organization, even outside of SPD. Know that there is something long term if they have that kind of level of drive. But then thirdly, there was something that you've talked to me about in the past, which is really this whole idea of the poverty level and how that connects as really the focus of a healthcare institution and how it is meant to serve the community. I think it would really hit this home.
Well, Justin, first of all, thank you for stepping in and saving me from myself and adding some of these things I talked about in the past about a career ladder, because that's very important. And that pairs with the educational part. But the biggest threat to health is poverty, right? And healthcare is one of the largest bankrupters of people in the country, right? They can't pay their healthcare dollars. The bill collector comes after them, and they get impoverished. It's unconscionable that we as healthcare providers who are supposed to be putting our values out in front, our mission out there, right, are doing something that we actually have jobs that don't allow people to get out of poverty. Like, we are actively contributing to this problem because we don't pay these people enough. We don't create a career ladder. We don't provide them the support and the environment they need, the opportunities to grow. And let's face it, a lot of sterile processing stuff, it's fascinating. This is a really complex space, right? There's a lot of supply chain in here. There's a lot of potential manufacturing. There's a lot of opportunity for personal growth if an institution is willing to get behind this, for people to really, get a hold of some of these problems, fix these problems, and then grow into leadership positions. And that's not happening. And we are actively impoverishing people by not paying them enough to this incredibly important job. So we're not putting our values out in front as healthcare organizations if we continue to do that. We are not confronting the biggest threat to health, which is poverty, within our own hospitals. And that's ridiculous.
Peter, I don't know where else to go from there. I think it's really probably the most important point that you can make on this topic and really center around something that is critical to just the growth of our entire industry. I don't think that necessarily applies only to sterile processing. I mean, that can apply to environmental services, right?
Environmental services is another, like, hospitals are filthy, right? I mean, if you go to, we talked about this, Justin, you go to like Silicon Valley where they do sterile manufacturing for computer chips, right? Those buildings, the people in environmental services, those are high-tech jobs. So everybody knows hospitals look at what happened to Seattle Children's. They had, what was it? Some kind of fungus growing in the vents of the ORs, and they had a bunch of deaths from this. Like, hospitals are not clean spaces. These are things we actually should value. Sanitation was something that, we figured out early on in civilization that would extend life. And we don't do that terribly well either. I think the other thing to point to is you look at MAs, medical assistants. If you look at the Kaiser system, they pay them well, and they also maximize them in terms of their capacities to deliver patient care. It is a trade-off, but it's their way of addressing a trade-off in terms of you're switching one type of professional out for another type of professional, but there's a massive nursing shortage nationally, and they are now, rising. These MAs are rising up to the level of doing certain tasks that nurses were doing. They don't get paid as much as nurses, but they're getting paid a lot more than they're getting paid in other healthcare systems, and they're functioning at a much higher level. It's a much more rewarding job. So it's not just sterile processing where this has to happen. There are multiple spaces where this needs to occur within healthcare.
Well, thank you for championing sterile processing and coming on to this episode. You're doing some really great work, and I know we're all looking forward to seeing some of the results of that research really coming out and backing up statistically everything that you're telling us and that many of us know inherently. So great job today.
Thank you. Thank you, Justin. It's a pleasure. Jeremy, Paul, great meeting you.
That was Dr. Peter Nichol, Chief Medical Officer at our sister podcast, Beyond Clean. And I love the topic of sterile processing. When I left nursing and moved into a sales and entrepreneurial type role, I definitely started out in sterile processing. So it's a space I have a lot of passion and energy for. Obviously found that commonality with Peter, and he and I have been working together on some of these projects as well. But, you know, Jeremy, you've also got SPD experience, and you talked about it early in the interview with Peter, you know, around the development of the certification and everything else. But I feel like there is much more momentum towards trying to champion and make significant improvements to the work environment and to how we reward and cultivate employees in healthcare organizations today. But you're all over the country. You're still living it. Is this echoing what you're seeing?
I think to a certain degree it is. It's catching on in some of your larger facilities. It's still lacking in a lot of facilities. I still hear sterile processing referred to as dishwashers. And I think the thing that we as OR nurses and OR scrubs don't realize is the impact that sterile processing has on our daily work. And we need to find ways to build that department up, whether it's additional resources, higher pay, those things that really can impact our daily life in the OR. And when you have a department that we're dependent on for our instrumentation and sometimes even our equipment, you know, we got to find ways that we can break down those silos and work together. And I think what Peter was talking about and the ways that the research that he's doing is just going to further that.
Yeah, healthcare is a business. And so the fact that that research is making the business case can only help pretty substantially. You know, he's got some great papers out there and articles. If you look him up, you'll definitely find them. It's been another great show. That's going to do it for this week, though. As a reminder, you can help support First Case by subscribing on iTunes, Stitcher, Google Play, and Spotify. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Jeremy and Paul and myself, thank you for listening to this episode of First Case.